on that note, we will get started for today. So if you just joined us in the room, good afternoon, good morning, good evening, wherever you are in the world. If you're in Click Meeting, you're welcome to ask any questions. Any questions that you ask in Click Meeting will not be seen by anybody out with Click Meeting. If you are on Facebook, bear in mind that you are in a public place, so your questions will be in a public domain. We are here to provide medical information as opposed to medical advice. And what we will try and do is take your questions, answer them as best as we can in a way that hopefully empowers you and gives you the confidence, information, knowledge, and the everything that you need to then take yourself forward. Also, the last thing I would say is that today's Q&A session in no way, shape, or form replaces the consultation you have with your own clinician. It's merely here to support that, inform that, and provide any extra help you may need for that.
The reason for that is that obviously we lack the backstory. You know, when clinicians see you, they go back through the record and everything else. They have an awful lot of information. However, if these sorts of sessions should suggest to you the questions you might want to ask your clinicians, then we have done our job.
Yeah, absolutely. Brilliant. Thank you. Okay, Professor Dave Jones, OBE. Question number 1. Any link between, we need the music in the background. Your specialist subject is, right, here we go. Right. Is there a link between PBC and body temperature fluctuations?
So yeah, no, I saw this one. Really interesting question. So the art with temperature fluctuations, and here's a tip for everyone, is that they split into 2. So the first is, are they genuine temperature fluctuations? Okay, and the answer could be yes or no. Right now, if you feel your temperature is going up, your temperature is going up. Well, it doesn't quite work like that, because your body has a certain core temperature around about 37. Although, you know, that's across a whole population. Some people will run a little bit lower, some people run a little bit higher. And your temperature per se goes up in infections. So to actually have a rise in temperature is usually a sign of infection, because the body puts its temperature up in order to be able to control it. Okay, so higher temperature allows the body to fight infections. Now, there are other reasons why you'll get a slightly high temperature, actual temperature, to do with the body fighting infections. So sometimes your body puts so you don't have to have an infection, the body thinks there's an infection, and sometimes there's some blood problems that the temperature will go up. Now, what about the other people who feel like they've got a temperature and haven't? And of course, you tell if you've got temperature by doing a temperature chart. So people very commonly from my clinic be familiar with going home to do a temperature chart. So 4 times a day, you know, do a temperature and then just jot it all down and see if the temperature is actually going up or not. The reason why people who haven't got a rise in temperature feel like they do is all to do with how the body controls where the blood goes. So your body switches blood flow into and out of the skin. So on a hot day, it puts so on a cold day is probably a better example. What it will do is shut blood flow from the skin and keep it in the core, because if blood flows under the skin, it's going to end up being chilled and your body temperature will fall. So that's why you get white hands on a cold day, is because the body has switched blood flow away from the skin to the core. Now, if you touch your skin at that point, it feels very cold. If you do a temperature, it can feel cold, but actually your core temperature is the same, because it's just the way the body operates it. Now, that's important, because most people, temperature control with PBC is actually to do with that shunting of blood around the circulation. This is where something that we've touched on before is a really important thing, is a thing called autonomic dysfunction. So how does your body switch where the blood flows? How does your body control heart rate and blood pressure and all of these things? Well, it's a thing called the autonomic nervous system, which is there to control those functions that go go on 24 hours a day without you thinking about them. So you don't have to think to breathe. Life would be very short if you had to remember to breathe. And that's because your brain sort of sends the signal to breathe. It sends the signal to breathe, right? Because it uses that automatically. Ditto your heart rate, ditto your blood pressure. So autonomic dysfunction occurs in PBC for reasons we don't quite understand, probably to do with the effects of the disease process on the system to sense blood pressure. And essentially, when you stand up from sitting down, your blood pressure will naturally start to fall instantly because blood starts to pool in your legs. Now, we all don't black out when we stand up because the body senses that. There's a blood vessel in your neck that senses that blood pressure drop. And so it sends a signal up to your brain, signal from your brain down to your legs. And the blood vessels in the veins in your legs are instructed to clamp down and return blood to your heart. And so instantly your blood pressure is corrected. It's the same principle as a G suit, which is used by a fighter pilot to stop them blacking out when the plane turns. In PBC, that is all to pot in essence. And it's very common for that sensation to not happen correctly. And so the reason why you get temperature perception differences is because of the failure of that normal process, and then the fact that the body flips into an alternative process to stop you blacking out, which is to put your heart rate up because it releases adrenaline. So temperature, oddities of temperature regulation and palpitations and facial flushing are all common in PBC. They are all associated with the sense of dizziness when people stand up, and they are all interestingly associated with fatigue. And a lot of the things that we do around trying to regulate that are in fact to try and control fatigue. So if somebody feels like they've got a raised temperature, the first thing to do is, have you got a true raised temperature, or is it a sense of a temperature? It's real to you, but it determines the direction you go down. If it's a real temperature, then it needs to get looked at if it's more than a few days, because obviously the potential for some sort of chronic infection or blood problem is there. But if it's an apparent rise in temperature, then it is around trying to normalize the autonomic nervous system. And there are sort of ways we can do that. Often it's about volume regulation. So the way to bypass it, you can retrain the vessel in your neck, the receptors there. So this is where we often tell people to drink clear fluid and various different things like that. So for most people, it's part of the autonomic dysfunction process in PBC. For a small number of people, it will be part of something else, and it needs its own investigation. So the first thing to do is to take your temperature and see whether it's actually elevated or not.
Okay, perfect. And in terms of sex specific, any difference between men and women in this?
Yeah, so there's an obvious one for women to do with the menopause. So the menopause, because of its hormonal effects, has genuine temperature fluctuations. So hot flushes are genuinely hot. So temperature will go up. Remember also thyroid function. So high thyroid can be associated. That really is like turning the stat up and down. So high thyroid levels can be associated with actual temperature. So those are other examples of it. In terms of the perception of it, no, that's not particularly gender related. We do know that autonomic dysfunction is a little bit less common in men than in women, because men tend to run higher blood pressures, but it can affect both groups equally. But it is really important. Get yourself a thermometer and do it at various different times of the day, because sometimes these kind of deep-rooted infections are worse at night. So you get night sweats and all of those sorts of things. So just do a series of temperature measurements, because that does dictate which direction you go down. 9 times out of 10, I can tell you, when we do this, there is no actual real temperature increase. It's just this blood shunting.
Right. Okay, that's helpful. Thank you. On the question of sex,
Robert, I only just know you, but it's nice.
Yeah, I know. So, mouse studies.
Yeah.
So I may be miles off the mark here. So, there are multiple opportunities for me to be wrong here, which I know is a situation that you're used to.
Yeah.
So, number one is an awareness that most of the mice used in experiments are male.
Yeah.
Because the females are used to produce more mice for experiments, basically.
Yeah.
Assumption number two, PBC has a general differences between male response and female response in certain circumstances. And number three, most of the patients that have PBC are women.
Yeah.
Could we be missing a trick because all the mouse studies are on men and all the human studies are predominantly women? Are we actually fudging ourselves by not actually asking the right question of the right things?
It pains me to say this, Robert, but that's a really good question, and you are spot on with your analysis. So, so I've said it now.
That's going to hurt.
I won't compliment you again. In the heart of all of that is a really important philosophical and practical question, which is how do you study a disease like PBC? And there is a tendency, or there was in the past, less so these days, that you take PBC and you then create a mouse model of it and you study the mouse model. And that's really quite easy to do because the animals are there and you do experiments and all of that. And it's you can get mice that are identical, they're genetically bred to be identical. So it's actually easy to do science. But it's a cop-out. And it's a cop-out because you are creating completely artificial situations. Okay. So there are one or two animal models of disease which are incredibly valuable. Okay. So there's a thing called the non-obese diabetic mouse, the NOD mouse, which literally appears to be a spontaneous version of human type 1 diabetes that is identical in every single way. Okay. So the immune response is the same, the effect is the same, the treatment is the same. And it's a chance model. It arose by chance, but it's incredibly valuable. It is mouse type 1 diabetes. It just is. And there are various other different models of mouse models of various different diseases, which are to a greater or lesser degree useful. Okay. And PBC, there are no useful mouse models of PBC. Okay. And I'll be very dogmatic about that. Now, the MRC, Medical Research Council, takes a very firm line on this, and their mantra is that the experimental animal of the 21st century is the human. And that sounds terrible, and it's not about people being used as guinea pigs, but it's to say, if you want to study PBC, why don't you look at people with PBC? And it's not a genius thing. And I think, that's pretty much, we did years and years ago, tried to find a mouse model of PBC, and it was a blind alley, if I'm honest. And so we principally work in studying humans because humans have PBC. There is one caveat to that about some of the brain stuff that I will come to in a second. So in general, people interested in studying disease in humans increasingly study patients, not experimental animals. I think it's ethically better. I think it's practically better. And the problem is that if you can end up going down a complete blind alley with animal research, because at the end of the day, the animals aren't people, aren't patients. Okay. Paracetamol is rapidly fatal in very small doses for cats. Okay. So if you had studied paracetamol in an experimental model in the cat, we'd never have paracetamol because it's a species difference. Okay. Yep. So you've got to be very cautious about it. And if you want to look in the history of medicine, look at thalidomide. People are very familiar with thalidomide, one of the worst examples of the side effects of a drug. But that drug was fully tested, It's just that thalidomide doesn't cause any problems in any species other than the human. Okay, so you've got to be careful with animal data. Okay, now, if you want to study a model of PBC, why do you want to do that? What aspect are you interested in? So if you want to study why people get PBC, you've got to study people, because there's no really sensible animal model that looks at why people spontaneously get PBC. If you want to study cirrhosis, why people get cirrhosis, actually ignore animals, because mice very rarely develop cirrhosis regardless. So that's not a particularly sensible thing to do. But if you want to study the effect of, say, cholestasis on the brain, the process of bile failure, then actually that's a sort of situation where mice are useful. So there is no mouse model of PBC, but there are actually quite useful mouse models of aspects of PBC that have allowed us to make rapid progress, which has led to clinical trials. So we did, having not decided not to do any mouse work, we went back and did a small amount to show the effect of not PBC, but cholestasis, the process in PBC, on the brains of mice. And did they respond to therapy? Yes, they did. And that now is translated into a human trial that's running in the UK at the moment. Interestingly, our colleagues in Umacrine is a company we've worked with on the next drug for brain fog in PBC. They have taken our protocol in the mice, repeated it, and their drug also reverses those processes in mice. And that gives us real confidence that these are worthwhile human trials. At this point, you move entirely into patients, because at the end of the day, that's what you want to do. So some amount of animal work is always necessary for toxicity, with the caveat that I mentioned, okay? With the caveat I mentioned. So that's important. But there are also some aspects of diseases where you can fast track your program of research into a trial, because you can't do a trial in people unless you've got really good evidence that it's going to make a difference. And sometimes, we can't do biopsies of people's brains. So it's really difficult to study that. And so those animal studies have allowed us to go from a really important clinical problem that we understand in patients in terms of its impact, to understanding the mechanism, to clinical trials. And it's allowed us to fill that gap. So that's the only types of animal work that we do. You're absolutely right. Most studies in PBC are done in male mice. And you're right, it misses a very important thing. But all of the gender differences in autoimmunity do not come out in our animal models of autoimmunity. If you look at mice, you do transplant work, a single dose of tacrolimus on one occasion will give them lifelong tolerance. They're just not the same. So I think rather than focusing on female mice, I would focus more on female patients and male patients while we're at it, and restrict the animal work to answering very specific questions. So we went down a blind alley with trying to model PBC. We've actually found it very useful to try and model one very specific part of it that then allowed us to move through to patient trials. But I think that comment about the experimental animal of the 21st century is the human is exactly the right way to go. So animal modeling, it can sometimes be a lazy thing that people go into because it's easier than studying patients. But we have to ultimately, it's people who get PBC, and so people are where you need to look. But it is a really interesting question. Most animal experiments, it's a very controversial area, are required by law as part of drug development. So, in a sense, in the early stages of developing a new drug, by law they are required to do that. So that's not a lazy assumption, that people make. It's actually a requirement. One of the things that we've done is done some work around, you can take cells from the skin of people, and you can turn those into stem cells, and turn those stem cells into any cell type you want, like bile duct cells or neurons. And actually those allow you to model in human cells things that were otherwise done. So I think that in the future we'll increasingly use these cell culture models to look at human responses to drugs rather than experimental animals. But that's a legal thing, and the law will need to change.
All right, thank you. And I appreciate your answer. And I think, one of the things that we do, we try and give the here and now, and we try and look at symptoms and quality of life, the medications, the treatments, and PBC and all those kind of things. But I think it's important every now and again just to look at the science and look at what we're doing. I know, you've got a whole number of specialist subjects, but one of the things that we come back to you periodically is, PBC in 21, PBC in 22, PBC in 23. What does it look like? What are we working on? And I think it's important to share the level of detail, the level of microbiology, the level of knowledge now. That that T cell does that because of that B cell, because of that protein, because of that, and all of that kind of thing. Just to let people see inside that bubble, and to see how much knowledge is going on, to see how much research is going on, and to see all the different strands that people are investigating to find the answers that we all see.
There's a really important concept in research called translational research. So, and this is about the philosophy of what people do and why they do it. And this is really important. So, back when I started in research, what you did is you started with some science and you did some more science, and eventually you worked your way to an application for that science. Okay, so that's what you did. So therefore, the logic was, if you understand why people got PBC, then you would work through to a therapy, and then you work through to this, that, and the other. And that's why developing an animal model to help study that makes a lot of sense. The other approach to research is to start with a problem and work backwards. Okay, so don't start with a mouse model of the disease that doesn't look really like PBC. Let's start with brain fog. Okay, so understand the nature of the problem, and therefore find ways to work back to why that happens, because once you understand why it happens, you can start to treat it. And once you think in those ways, pretty quickly, you need to study lots of people to work out the nature of the impact. You also need to think of ways to measure it, because if you can't measure it, you can't look at whether it improves in a trial. So it's philosophically a different type of research. And it's where the UK is actually a world leader. So the UK really does translational research. It's to do with the funders we have, the Medical Research Council, people we're familiar with, the National Institute for Health Research, people we're less familiar with, but that's the research and development arm of the NHS. And very much that's their ethos. I worked, when I was around less for a few years, I worked for NIHR for 6 years on training the next generation of people in translational research. So it's very close to my heart. That largely you're better to start with the problem and work backwards to the science. Occasionally, you need to start with the science and work your way through. But if you look at all the progress in the last 20 years compared to the 20 years before that, that's because of the move to translational research. Rather than answering the abstract questions that people found interesting, start the question, answer the questions that are important to the patients, and work backwards. It kind of adds to the relevance of what you do. Just going back to Robert's point about research, the other thing to say, of course, is that one of the things that people like me who are steeped in this is you're kind of aware what's going to come, this year, next year, the year after. So the process by which things get into the clinic takes a length of time. So we kind of are aware of the pipeline. So sometimes we talk about things that nobody else seems to know about, and that's because in the science world, that's what happens. You go to meetings, you hear, you talk to people, you're aware of things. So, and the future is very bright for us in this world, for you, every confidence that the recent kind of progress will continue. But we are just sort of aware of all of that. So research, goal-directed translational research is what's made the difference.
Okay, perfect. Thank you. I appreciate that. Right, I'm going to throw some Greek at you. So this could come out any way, shape, or form. But the question is doxycycline okay to take with mycophenolate mofetil and tacrolimus? Somebody's got a chest infection. They're on their second course of something. I'm assuming it's the second course of doxycycline, but it's not shifting the chest infection. Should I ask for a type?
I will just talk amongst yourself. I will just check for you. I don't know off the top of my head. but I can soon find out.
Okay. So Dave is checking the online version of what we call the Big Blue Book, which is a document that's updated, I think, monthly, which looks at contraindications between medicines. So if a medicine interacts with another medicine, and an example of that would be cholestyramine. So this is the gel that you mix with water or a wee hint of orange juice, which then is used as the first line therapy for itch. And you're always told when you take your cholestyramine to take it away at least 4 hours away from any other medications. And that's because it's known to soak up anything that's taken within that time, and then it just kind of disposes it out of the body. So these are the kind of things that the Blue Book used to tell us, and the online service now does. So
I knew I'd actually found out the answer a little while ago, but I was just watching you blag it. It was quite entertaining.
Thanks for that.
And the answer is that's completely safe.
Okay, perfect. Thank you.
It's just the sort of thing that no doctor should, in those situations, no doctor should attempt to remember all of these things, because not mycophenolate and tacrolimus, we use those a lot, particularly around transplant, but also overlap. But doxycycline is not something used that commonly. So the safe thing to do is always to check the online resources, but there are no interactions there.
Okay, perfect. Thank you. So we have a whole lot of unanswered questions from the conference, and we're looking forward to working on a document. So the next Bare Facts is going to be a conference special. And so there'll be bits from the presentations, there'll be some really great takeaways, and then we're going to do a big monster written Q&A session for everybody to take and to keep on their coffee table. We actually have an unasked question. I forgot to ask at the weekend, is there a correct time or times of the day to take your ARSO?
Yeah, good question. So we recommend to people to take it in the evening, in one dose. And the reason for that is sort of twofold. One is it allows you to space it away from the Questran. So as Robert said, Questran and ARSO don't go well together, not because it's harmful, but because one binds to the other and neither of them has an action. So you lose the benefit of both. So you have to space Questran and ARSO out, and people take Questran up to 3 times during the day. So the way to be able to do that quite easily is to take the ARSO at night. The other reason is that it actually works best for the way ARSO needs to work in PBC, which is in the liver. Now, the reason why the books say take it 3 times during the day is because in the old days, ARSO was used to dissolve gallstones. That was how it was invented. And it's never used for that anymore. But because you need to get it into the gallbladder, it's better to split it during the day. So the fact that it says in the books you take it during the day, it just reflects the old-fashioned use for it. So we take, it's not a big deal, by the way, and if it's easier for people to take it during the day, that's absolutely fine. But we tend to recommend people take it in the evening. So we don't use ARSO to dissolve gallstones anymore. But the one thing we never see anymore in PBC patients is gallstones. So I suspect that the fact that people take it, or there'll be people on the call, I'm sure, who are the exceptions to that, but we never used to. Gallstone problems were very common in PBC in the past, and we don't see them with any frequency anymore. And I suspect that's a long-term effect. It's just if you got pain every day from your gallstones, the 2 years for ARSO to work isn't that great a deal. So probably lasting in the evening, but it's not a big deal. If that gives you a lot of GI disturbance, and it's difficult for you to do that, then obviously it's better for you to take it during the day than to not take it.
Okay, perfect. No, that's ideal. One thing I would say on behalf of the foundation is that because your dose of ARSO is important, that actually if you take it all at once, it's an aid memoir as well. So you've got less chance of losing a dose. Maybe you forgot at lunchtime, or you were out, or those kind of things. So actually taking it all in one block means that you will take all your medicine. It helps you do that.
Robert, have you by any chance got an easy way for people to work out if they're taking the right dose of ARSO?
Oh, you.
Sort of something useful to help people be able to take the right dose. Oh, you do have that.
One of those.
This is a standing joke, by the way, for those of you who don't realise, is that we always end up mentioning the calculator. URSO is one of these drugs you have to take the right dose for your weight, okay? And sadly, weight can go down, but sadly it can go the other way as well. So just make sure you're taking the right dose, and it's a bit fiddly to calculate it. So the foundation has a really simple calculator.
So I'm not saying that I'm always prepared for when I work with Dave. There's the compendium, in case the compendium gets mentioned. There is the lay version of the EASL guidelines, which we co-authored with Dave, in case those get mentioned. And obviously, we've got previous issues of the bare facts, in case they ever get mentioned.
Yeah. So the calculator,
GP-specific leaflet, though, I'm in trouble. So.
And of course, the app.
Indeed, absolutely. No, I appreciate that. Okay, next question, if I may. Again, it's a bit specific, but again, the general information would be helpful. So somebody was diagnosed in March following 18 months of consistently raised ALK-Phos and GGT. Negative AMA and negative PB-specific ANA.
Yeah.
Imaging tests, all normal.
Yeah.
Symptoms of itch and fatigue present.
Yeah.
The good news is normalization of ALP and other bloods following 3 months of ARSO has happened. But in lieu of the AMA, would that confirm a diagnosis, or would a liver biopsy still be best practice?
The challenge there is that you end up treating blind. Okay, so I don't know if you mentioned the age. Did you mention age, Robert?
No, it's not in there. Sorry.
So the commonest reason for a raised alkaline phosphatase in a woman over the age of 50 in the UK is PBC. Okay, so it's a rare condition, but actually in the target population isn't that rare. Just a really important point that cropped up in a conversation at the conference is that we talk about alkaline phosphatase, but if your gamma GT is elevated, that carries just the same diagnostic significance as alkaline phosphatase. Okay, so that's equivalent. And whatever your doctor says, gamma GT is not only elevated in people who drink. It's an urban myth, and it's completely wrong. So just file that away. So statistically, this sounds and looks like PBC because you've got the alkaline phosphatase elevation, but also the symptoms. So the certainly, to us who talk to a lot of PBC patients, the itch and so on are very characteristic. Technically, to make a diagnosis, you need to do a liver biopsy. So would in that situation never be the wrong thing to do, but is it the right thing to do? Well, what I would do in this situation, because if we ever organise a liver biopsy, Robert phones me up and tells me off. What I would do in this situation is do a blood test called the IgM. Okay, IgM. Now, this is a measure of one of the blood antibody levels, and IgM is the first response one that your body produces after an infection. And almost the only reason why it's ever elevated is PBC, okay? And it isn't part of the standard diagnosis, but we use it as a tiebreaker, okay? As a tiebreaker. So in these sorts of situations, I would do an IgM, right? If the IgM is elevated, you've got PBC. And as long as you're comfortable with there being a little bit more doubt than there would be if the AMA was elevated, I would treat it as PBC and act as if it was PBC, because it's too much of a none of the other the only other condition you get a raised IgM is a thing called Waldenstrom's macroglobulinemia, which isn't that common, right? So for me, if you've got raised alkaline phosphatase, right age and sex for PBC risk and PBC symptoms, and an IgM, it falls under if it walks like a duck, has feathers and quacks, it's probably a duck. And anyway, if you've got a full response with a good response with URSO, you've kind of got the answer. If the IgM is not elevated, then I think the right thing to do is liver biopsy, because you may well end up masking something else that needs its own treatment. If you get an incomplete response to ARSO, again, it could be a masking phenomenon. So I think as long as everyone is confident that there is a kind of uncertainty about it, then it's an okay thing to do. But that's because I'm kind of confident diagnosing PBC. Other people may think a biopsy is a sensible thing to do. In a lot of situations we would do that. But the IgM as a tiebreaker is really useful. But that's a good question. IgM is really useful in PBC.
Wonderful. Okay, that's ideal. Thank you very much. Again, a bit of a specific question, but we'll go with it and see what else we can produce with us. I have been on amoxicillin trihydrate, and potassium clavulanate, for a severe sinus infection I've had for a month. I've developed ulcers inside my lip. The GP said this is because of ARSO in combination with penicillin. First question, is that correct? And secondly, can we prevent this? And third question, again, at the risk of embarrassing myself, I'm going to bring up lichen planus at this time, because I think that's around mouth ulcers as well, and that's a common question that comes up. So, thoughts, please.
So, the combination of amoxicillin and clavulanic acid it goes under the trade name Augmentin. Okay, so that's Augmentin that many people will have come across. It's also known as co-amoxiclav for generics. Okay, and it's a version of penicillin. And the reason to give the clavulanic acid with it is that clavulanic acid blocks the process by which bacteria are resistant to penicillin. So penicillin resistance is a problem with a number of different infections. So that was why it was introduced. It's a very useful antibiotic, and it's used particularly for ear, nose, and throat things. So that makes sense with the sinuses. Okay. I don't think there's any interaction at all between clavulanic acid and amoxicillin and ARSO. I think that sounds like a bit of nonsense to me. And I think you've been sold a bit of a line about that. So I've certainly never seen mouth ulcers with PBC. Augmentin is pretty widely used. Augmentin is a funny drug, and all hepatologists slightly cringe with it because it causes quite significant liver injury very rarely in people, and it causes cholestasis. So it's one of the drugs that can cause liver injury. We call it drug-induced liver injury, or DILI. And pretty much every drug very occasionally can cause liver problems, but there are some usual suspects, of which co-amoxiclav or Augmentin is one of the usual suspects. So we are not that wild about it because we kind of see the downsides of it. That said, cases of toxicity are very rare, and it's used in vast numbers of people. So per prescription, it's very, very uncommon, but it does happen. I don't think there's any evidence it's worse in PBC. I've certainly not seen the combination, but it is important, if anybody ever develops liver problems with Augmentin or co-amoxiclav, never to take it again. It's one of these ones that accelerates, it's called. So the first time you get it, it causes a minor problem. The second, it's severe. The third time, it kills you. So it's one of these things where it's really important to avoid it. So generally speaking, it's not something I would tend to want to use in PBC patients. For that reason, we haven't got a lot of experience of interactions, but I don't believe for a second it interacts with ARSO.
Okay, perfect. Thank you. Right, again, a fairly specific...
Lichen planus.
Yes, please.
Okay. So lichen planus is...
well done.
Is one of the unusual kind of autoimmune phenomena. So it's where you get sort of deposition on your just over there, but you also get mouth ulcers with it. And it's like a lot of these things, slightly linked with PBC, although it's pretty uncommon. It's commoner than PBC, but PBC is uncommon. It's uncommon, so you don't see it at all commonly, but it's something you do see. So cutaneous lupus is a sort of skin version of lupus, we see that, lichen planus, erythema nodosum, where you get sort of red lumps on the leg. All of those kind of autoimmune type things are commoner in PBC. Now, the important thing about lichen planus is that the lesions on your wrist there are very itchy, and obviously it's one of the things that people can confuse. So again, I'm giving away the tricks of the trade here. The way we teach junior doctors when they're not on strike, which seems to be all the time these days, but what we do is that you don't try and look at a picture and work it out, try and look at everything. You go along a pathway and you determine at each step which direction you go. So we did it with the temperature, right? So if you feel like you've got a temperature, the first question is it a temperature or is it perception of a temperature? And then you go up all of those things. So it's like with itch, the first question should always be, do you have a rash with it? Because if an itch has a rash, it's one set of possibilities. If the itch doesn't have a rash, it's a different set of possibilities, with the caveat that people can cause skin irritation by scratching. And a PBC, of course, classically is one of the causes of itch without a rash. I have seen people with lichen planus and PBC, and their itch is quite different, interestingly. So they can tell me whether it's the lichen planus that's making the itch worse or whether it's the PBC. So it's a different characteristic. The lichen planus one is more on the surface. The itch one is the PBC one is more under the skin. So it's for those of us who are, obsessional about the words people use and the information you can have from it, then it's you can decipher it. We've got, when I'm not doing PBC stuff, I do a lot of training work here, helping the next generation of translational researchers. So I get to talk to people about very interesting projects that they're doing. And we've got somebody who is taking the words of patients and their families to describe their problems and using it to diagnose different types of dementia. So these are people with dementia features, but can you diagnose which type it is and therefore which treatment might be appropriate based on the words they use, all done with artificial intelligence. So people are asked to talk about their dementia symptoms in themselves or their loved one, and then they're analysing that to see if those words actually will help with the diagnosis. And it's fascinating stuff. And I do wonder, actually, you could apply a similar thing to fatigue in PBC to be able to, we do this dissection of what people actually use, but you could actually use almost an AI type of approach and do all of that. So the point we make to the junior doctors is the words people, structures to how you do things, but also the words people use are immensely informative.
Yeah. There's an amazing guy that I met last year, Tim, I'll think of his name. Now, he is working on an AI app type project for rare diseases.
Okay. Yeah.
Using the exact same principle. So when patients put in the keywords, or even if GPs are using it, if these are the keywords, what are the rare conditions I've not considered, and then start to. So again, an amazing use of tech.
So AI is one of these things that everyone talks about these days, and it is both a fabulous opportunity and a sort of red herring in equal measure. Like a lot of these things, it's what we call the next big thing, and apps were with no disrespect, but apps were going to answer everything and exercise. So you get this in medicine, a bandwagon effect. The real power of AI is that it takes away a key part of human fallibility, which is that sense that once you see a picture, you can't unsee it. And the example I always use is the famous picture and the black and white on two sides, and one's an old lady and one's a beautiful French woman. And once you see it, we all see it in one way, either the old lady or the French woman. But once you then see it again, you cannot do anything but go back to what you originally saw. And so humans recognize patterns, okay? And you can't unrecognize patterns. The danger with that is you get reinforcement bias, is that if you've seen a picture, everything that happens that confirms that, you see that again, and everything that goes against it kind of, there's a reason why it doesn't apply. And it happens in so many things in life. People, we are often, when we're looking at when things go badly in, organizations and things, why did this happen? Well, the answer is somebody made a mistake earlier on, and everyone then reinforced it because they all kept seeing the same thing. And nobody took a step back and said, is it something different? Okay. And, there have been lots of things in the news that were fit into that, is that groupthink comes along and somebody sees it and can't unsee it. And then everyone goes along. It's the emperor's new clothes, if you like. The point about AI is that machines don't behave that way. They will always continue to question it. And you think, what's that got to do with anything? Well, we know that, for example, mammography for breast cancer screening, the day of the week and the time that people look at the x-rays actually pays an effect on the errors that are made, right? So Friday afternoon, there are more errors than there are on Monday afternoon. And that's because people are human. And the 14th set of x-rays you've looked at, if that 14th one is the one with the abnormality, people's minds wander. And that's where AI comes in. For 24 hours a day, it does it objectively according to all of its things. And if you set the bar right, so when it flags abnormalities, it's a fail safe. So for me, power of AI is in something like that. Mammograms are best read by really competent doctors, but after the doctors read them, they are then checked by the AI program. And if it sees any reason for concern at all, it returns it with a flag. And then that's looked at in a different way. That's how I think AI is really useful. Doesn't replace doctors. It doesn't, that's the wrong way to think about it. It is that never sleeping fail safe that allows us to cross-check without human fallibility.
No, that's perfect. Thank you. We got a question from Australia. Can you suggest the best medication for itchy skin?
I was out in Australia earlier this year. Talking to people interested in finding out about PBC. I was in Melbourne, then Sydney, and then Brisbane. And I realised that people elsewhere in Australia are very rude about people in Brisbane, which I hadn't realised about. And they call it Bris Vegas, which I think is a bit harsh. Yes. And the good news is that that they're really getting their networks around PBC sorted out in Australia. That's really helpful. And there are some really good PBC people in Australia. A lady called Kate Lynch, who I think is in Melbourne. But she might be in Adelaide, actually. She trained with us and did a lot of research. Kate Williamson, you may remember her from Oxford. Robert. Yeah. So there's some really good people there. So that's really great. So for itch. So what you do, so if you're going to manage itch, you take a structured approach to it. So the first thing you do is always be on ARSO at the correct dose, because that underpins everything we do. The textbooks will tell you that, and the guidelines will say ARSO doesn't treat itch. Okay. Actually, it does. It's not the preferred way of treating itch, but it will benefit a number of people like that. So first and foremost, ARSO at the right dose, and then you assess what the problems are afterwards. At this moment in time, the only licensed treatment for itch is cholestyramine or Questran that we've talked about a little bit, which is sachets that are mixed up. They sit in the gut, bind the bile acids that probably drive the itch. And it's been a treatment that's been used for donkey's years. It is very safe. It doesn't have any significant side effects. However, it's quite difficult to take. It has quite a bitter taste to it, and people don't like it. So for that reason, it's not a brilliant treatment. It's also not the most powerful treatment. So we tend to use Questran, cholestyramine, because it's licensed. And we need to use the licensed treatments before we go into other non-licensed. So this is where it gets complicated. So there are a number of agents that are perfectly licensed. They're well understood drugs, but they're not. Their normal use is not PBC itch. And so it's important to try the thing that is the treatment of PBC itch first. So after that, we have a range of treatments that we use. For us, we tend to use a drug called rifampicin, which is an old-fashioned antibiotic. The fact that it's antibiotic is neither here nor there. It's not its antibiotic action, but that's highly effective for itch. You have to watch. Liver function with it, because it can sometimes make the liver a little bit worse. Very rarely, that returns to normal if you stop it, but you need to have your blood tests checked. You start a low dose, 150 milligrams a day. Check your blood tests, and if need be, you increase it a little bit. But that's our go-to treatment for people who've not settled with Questran and ARSO. And it's really effective. We've had people on it for 20 years with perfectly good control of their itch. There is a drug called bezafibrate, which fibrates are a class of drugs that are increasingly used to control PBC. Bezafibrate is not, however, available in Australia, but an alternative for it called fenofibrate is available. So everything I've said would do with fenofibrate, right? So fenofibrate is available in Australia. It's used quite widely. That seems to benefit itch. In our hands, it's less effective than rifampicin, and we would use it after rifampicin. So ARSO, Questran, rifampicin, bezafibrate, stroke, fenofibrate is probably the things that we would do. And after that, you're into quite specialized things, okay? In specialized things. And the reason is you're into the small print. So after those, our go-to drug is a drug called gabapentin, which many people will be familiar with, about controlling nerve pain, but also works for the itch. But at that point, you need to be talking to somebody who is comfortable with all of those things. And there are a number of trials of new and very interesting drugs going on at the moment. We don't have the perfect treatment for itch. We have lots of options. As I always say to people, they all have a but. You know, Questran is very safe, but it's a bit bitter to take. Rifampicin is great, controls lots of people's itch, but it causes a bit. So we do need we need paracetamol for itch is what we need with PBC. But I would use those drugs in that order. We can always control itch, okay? Always control it. So you shouldn't sit there with difficult to control bad itch. That's usually because people haven't tried hard enough. And we see people come into our clinic with impossible to treat itch, and it's always treatable. You just need to pay some attention to detail. So it is really important. And don't forget, itch is the kind of linchpin symptom for PBC, because if you have bad itch, particularly at night, then you don't sleep, then you get fatigue, then you get brain fog, then you get depression. So it is the symptom that you can get rid of lots of other problems often if you control it. So I hope that was useful.
All right, perfect. Thank you. That's a great answer. So we've got somebody who has had an MRI and an MRE with good results.
Yeah.
One doctor, not the hip, is saying get a FibroScan, and the hip saying you don't need the FibroScan because your MRI and MRE were fine. So the patient's not entirely sure what to do. Obviously doesn't want to upset either doctor.
So MRI, magnetic resonance imaging, is usually cross-sectional. It's like posh CT scans. So it's like a CT scan, but you get a lot more information. And so we use CT and MRI in slightly different situations in order to get different information. But they are the sliced images to look at what's going on. You can also use MRI in certain situations to measure chemicals in the body. So, which isn't about imaging, it's about measuring things. So MRI is a much more powerful tool than CT. It takes 45 minutes to an hour to do an MRI scan. And it's also in a much more enclosed scanner. And so people often find it very claustrophobic. So MRI is not really a replacement for CT. It's the next level up, and you would do it if you need to do it. Now, MRE, I've never talked about here, okay? And that's the reason for that is it is only available in a very small number of centres. So we don't have it here. MRE is magnetic resonance elastography, okay? And it is a much better version of FibroScan, okay? So it is an alternative to FibroScan, but it's actually a much more accurate version of FibroScan. So anybody who's had an MRE does not need a FibroScan. The hepatologist is correct. The only thing I would say about MRE is that people are much less familiar with the data from it. So anybody and everybody can discuss a FibroScan. Your clinician could phone me up and discuss a fibrous scan, and we could all understand what a particular value meant. Because MRE is only available in certain centres, people don't have that familiarity. So that's the only caveat, is that once you're unfamiliar with dynamic ranges and what a particular value means, then sometimes things can be missed. But MRE is in fact a superior technology to fibrous scan.
Perfect.
It is probably, to me, not a sufficiently valuable enough technology to put somebody through a scanner for 45 minutes compared to a 2-minute fibrous scan. I don't think it's that much more valuable. But if they were doing an MRI anyway, it's a very sensible, use of the time.
Okay, perfect. Thank you. Question laden with specifics. Somebody is AMA2 positive, ANA speckled positive, IgM 8.6. Rheumatoid factor 626, oligoclonal bands type 4. Glad that means something to you. Gamma GT 686, ALT 79, AST 66, LP 121. It says 121 stroke 141. So I don't know if that's kind of between 121 and 141 or 121 with their upper limit of normal is 141. I'm not quite sure yet. So not on any treatment. Been told that PBC and my Sjogren's connective tissue disease are the primary cause of my sensory ataxia, myelopathy, and dorsal column dysfunction. Is this a normal advanced side effect of PBC that's been left untreated? What should I be doing?
Can I ask whoever asked that question just to pop in the chat what age they are? That'd be quite useful.
Right. So this was a pre-written one. So we'll see if that person's on. We'll get an answer to that.
Right. Let's go through all of that. So the M2 is a version of AMA. So if the AMA is positive, that is in the spectrum of PBC. Okay. The speckled pattern for anti-nuclear is one of the nuclear antibody patterns you see with PBC. Okay, so the antibodies say PBC, although they clearly don't exclude other things being there as well. The IgM is very elevated. We said IgM is a tiebreaker. Don't need a tiebreaker here, but that's really high. So I think 3 to 3.5 is the upper limit of normal. So that's really high. So remember what I said before? All of that says PBC in one form or another. The ALK phos is not that elevated. 121 isn't elevated. 141 is. So it's minimally elevated. But the gamma GT is very high. And what I said earlier, this is a great question because it actually illustrates all the points we were making before. So remember, gamma GT is as diagnostic, as accurate as alkaline phosphatase. So whatever else is going on, you have PBC. And the fact that the ALK phos is relatively low indicates that it's probably relatively low activity stroke early. However, would I give you ARSO without question? Without question, I wouldn't think twice about it because there is clearly some component of PBC going on. Rheumatoid factor is an autoantibody associated with rheumatoid arthritis, and it's a terrible clinical test. AMA is a really good clinical test because it is accurate. If you've got AMA, you've got PBC. If you've got PBC, you've got AMA to a 95% approximation. But rheumatoid factor is often elevated in the population. It's often not elevated in rheumatoid arthritis, and it's not that useful. It is also subject to false positives, i.e. it comes back as positive when it isn't truly positive, and it is very susceptible to high IgM levels causing false positives. So that gets 2 question marks after it. So obviously, if you've got joint problems that sound and feel and are like rheumatoid arthritis, then it's definitely there, but it's not a great test for rheumatoid arthritis. The ataxia and the other neurological things, those are really important other autoimmune phenomena. So those need to be looked at. They're not common in PBC at all, and those need to be looked at. Things like vitamin deficiency, B12 deficiency, folate deficiency can all be caused on all of those things. And I think therefore that needs specifically looking at by a neurologist to join the dots. So if the question is, have you got PBC? Yes. Should you be treated? Yes. Is it mild or aggressive? Looks very mild, but that's the reason why you want to treat it now rather than in 5 years in the future when it may be more severe. But all this falls into the category of what I'd call complicated PBC because it has other associated features. Generally speaking, you want in those situations to be looked at by the different experts who are experts in each individual component. So if you were in Newcastle, you'd be seeing me about the PBC, my good friend and colleague, Professor Fai Ng, about the Sjögren's, who's the Sjögren's equivalent of me in PBC. And you would be looking at to go and see one of our neurologists about the neurological problems. People I know want to go to a single clinic, but in these situations, you're talking about rare stuff, and you can have a kind of lowest common denominator type of view with somebody who'll have a crack at all of them, but you want the best for all of those things.
Okay, perfect. That's helpful. Thank you. Next question.
The antibodies and IgM are completely clear cut for PBC there.
Okay, perfect. Thank you. Diagnosed PBC 18 years ago. I haven't seen a consultant since 2018.
Yep.
My GP keeps an eye on my bloods. Is there any other investigations I should be asking to get done to keep up to date with how PBC is affecting me? I currently take ARSO and Ocaliva and basically have no symptoms.
Okay, so the GP is keeping an eye on my bloods is one of those expressions that always worries me. Ronald Reagan once said that the 8 most terrifying words in the English language are, I'm from the government and I'm here to help. So mine are, the GP is keeping an eye on things. But they were keeping an eye on the iceberg on the Titanic. They spotted the iceberg, but they still went into it. So keeping an eye on things is not necessarily the same as having it completely under control. So the best person to keep an eye on your bloods actually is you. Know what your alkaline phosphatase is, know what your gamma GT is. Because I've got plenty of experience of people being kept an eye on and things get missed. Okay, so I think that's great, and I may be traducing your GP who's absolutely all over this, but we see a wide spectrum of quality of kind of input into these things. So I think that you'd probably agree with that, wouldn't you, Robert? Which
100%. And what I'd say to you is, if you've asked this if you've asked this question, give us a call and let's talk in more detail and let's see.
So it's all about what the values are. And if your alphos is normal on that combination of therapy, then that's absolutely fine. Other blood tests, not particularly. So pretty much all the information we want is in liver function tests. I think all PBC patients should have their thyroid function tested every few years because thyroid is the commonest of the autoimmune conditions, and that can creep up. So we tend to do that. There is no point in redoing the autoantibodies. If you've got a diagnosis of PBC, you're on treatment for PBC, then I wouldn't do that. So the other thing that's probably worth doing is a DEXA scan, bone mineral density. We recommend that between 1 and 5 years, depending on what the values are. So if your values are completely normal, it's every 5 years. But if you're at risk, it's down to every year. So that's important. We used to see a lot of fractures in the old days. We don't see any fractures anymore. That's because of attention to detail. So pretty much the liver blood test plus a thyroid function every so often. Obviously, URSO and a beta-cholic acid is a combination. That's a second-line therapy combination. And quite correctly, a beta-cholic acid is much more routine in the way it's used. We wouldn't send anybody on a beta-cholic acid to be managed by their GP, okay? Because you've kind of crossed the bar into being higher risk by definition. So that's locally, we would see everybody, kind of once a year, but that's not mandatory. It's, that's just what we tend to do. So I guess the devil is in the detail of what those bloods are. If they're completely normal, then there is literally no reason to think that will change. We know from the combination of URSO and beta-cholic acid, we've now followed people for up to 10 years. And whatever effect you get with obeticholic acid by 3 months, it will stay like that forever. Okay, forever. So it's not something where the effect wears off or you're going to need other things. But there is also a tendency to want to tighten up. And we are increasingly using the combination of ARSO, obeticholic acid, and bezafibrate as triple therapy in anybody whose blood tests are still even slightly abnormal. So the other aspect to this is that the goals of treatment are also changing. So your GP may be following a script, but there may have been a change to that script. So Robert, I think if you're just happy to chat about your blood tests, Robert can point you in the right direction. If you've got a caring GP who gets PBC, is managing all of this and keeping an eye on it, and your blood tests are normal, that's actually literally perfect.
Yeah.
But that's the exception, not the rule.
Okay, perfect. Thank you. Is it inevitable for compensated cirrhosis to eventually become decompensated cirrhosis?
Absolutely not. Absolutely not. So I have managed people who have had compensated cirrhosis for literally decades. And I always tell the story of a man with PBC, and he had normal liver function. Okay. And my senior colleagues in those days liked to do biopsies on everybody. It wasn't me, Robert. I was just the person doing it when I was a junior doctor. And he had the only significant complication I've ever had doing a liver biopsy. So he had a loop of bowel beyond the liver, completely unidentifiable, but ended up catching the bowel, had a small bowel leak. It all wasn't a problem, had to be managed. The irony, of course, is that he was the father of a friend of mine, and I was literally never allowed to forget about this ever. The point was his biopsy showed cirrhosis, okay? And I then ended up seeing him as a consultant and managing him, and he died of old age, still with normal liver function tests, still with cirrhosis, and still with no complications, okay? So the answer is absolutely. It's not uncommon to see people who've got more advanced PBC at the point of diagnosis because it was picked up late, who'd progressed to cirrhosis, then come completely under control. So what do you do with somebody who's got cirrhosis and is not decompensated, so is fully compensated? The first thing is absolutely get the disease under control as much as you can, okay? So it's even more important to control the disease to prevent that from getting worse. So it isn't the fact that there's cirrhosis, it's what the rest of the liver is doing that matters. So it's doubly important to get those liver function tests to normal, okay? Doubly important to do that because that's what stops this from decompensating down the line. Okay, so that's really important. Now it gets quite complicated because increasingly people are concerned about using the second line treatments like obeticholic acid and bezafibrate in people with compensated cirrhosis. So I think if you have compensated cirrhosis and you have liver blood tests that need second line therapy, that's the time to go and see one of the specialist centres because we have no hesitation treating people in that situation. But I would want to do that myself or my colleagues in Birmingham or Cambridge or London, where you're just a little bit more comfortable. You've treated large numbers of people. So it's cirrhosis plus active disease is the sort of thing where you need to be under a specialist centre. I think that's very important in that situation. If you've got normal liver biochemistry on ARSO, then actually that's absolutely fine, and that simply will continue with that way. Now, if the worst comes to the worst and you have a variceal bleed, right, it happens, you also don't panic. The important message here is don't panic. So if you have a variceal bleed, you absolutely don't panic, because what will happen is that will knock the liver a little bit and then it will just return to how it was before, okay? So one decompensation does not predict another decompensation, provided you pay attention to details. In that situation, you need to manage the varices, start you on beta blockers, make sure the disease is under control, and back you go. And so we very commonly see people who very first present, well, not very commonly, we used to see more commonly now just occasionally. Their first presentation with PBC is with a decompensation episode with cirrhosis, and they never have another one. Okay, so it's just doubly important to attention to detail. That situation, you should never be managed by the GP. Okay, that is hospital stuff. And I would, given how rare cirrhosis is these days, for me, that's the sort of thing that should be looked after by, and Jess Dyson, who's my colleague who manages all our people with cirrhosis or around transplantation, she would always say she wants to know about those people. She wants to look at them, see them, meet them, get a feel for what's going on so they're aware of it all, even if they're then predominantly managed somewhere else. Just useful for people to just know they're out there in case it's unpredictable. So the two key words are don't and panic.
Okay, perfect. Thank you. One thing I would add, if I may, from the Foundation's perspective, and again, Dave, feel free to correct me at any point. When you look at histology and cell change, actually, let's go the other way. When you look at liver biochemistry, that's a measure of what's happening here and now, what's going on in your liver, and what the various compounds are and the various elements that are in there. And then that has implications in terms of what happens in the future. In terms of your histology and your cell change, that is an indication of what has happened in the past. And what has happened in the past is not necessarily an indication of what's going to happen in the future. And as Dave has alluded to, that actually treatment can stop that process that's happened previously and make a difference to your health.
Yeah, and that's why FibroScan is so useful, or MRE if you have it, because that the bit that we have is the blood test, which is what's going on now, and which will give you future injury, and that's very useful. But we didn't really have an easy handle on what had happened in the past, and that's where you should never biopsy to look for cirrhosis. That's historic. So that was always difficult. And that's the gap, of course, that FibroScan has filled. Because and genuinely, if you have a FibroScan, I saw a lady in the clinic, early diagnosis, sharp GP, picked it up, came along. She's got normal liver biochemistry on ARSO, and we did her FibroScan. FibroScan's 4.5. So you have the backwards look, there's no injury. The forwards look, there's no injury going on. And that's all really good news. But she has significant symptoms. And I keep making this point. The fact that you've got well-controlled disease is neither here nor there in terms of symptoms. You want to control the disease always in everybody for obvious reasons. But if your doctor says, oh, you can't be fatigued, your liver blood tests are normal, you haven't got cirrhosis, it's nonsense. The vast majority of people in our symptom clinic have completely controlled livers. It's just they also have symptoms.
Perfect, thank you. I'm aware of time, so I've got one more question for you. Before we do that last question, just to let you know, we've had a follow-up comment, and the lady who's been seen by the GP has normal LFTs, and they have been that way since starting workup. So maybe, just maybe, it was that perfect scenario we were all hoping.
Then that's the perfect scenario, and absolutely. And I think, that's what we're after. We're after normal. The really good, that's really useful to know. That's very important. So the answer is, it doesn't matter who's watching, as long as somebody is watching and acting on what happens. And regardless of anything else, it's important that you know what the tests are doing, because you've got much more vested in all of it. I mean, the really good news, if you've normalized on OCA and ARSO, the really good news is all the evidence we have from long-term follow-up is that it will stay precisely like that without change.
All right, perfect. We've had a cheeky wee one come in, so I'm just going to say quick yes or no. Can you fly if you've had a varicose bleed?
Yes.
Okay, perfect. Right, here's the question I was going to ask you. So,
yes, it's an urban myth that it decompresses your portal circulation, but obviously you've had a varicose bleed. I mean, nobody should have two varicose bleeds, okay? You have a varicose bleed because that's how it all comes to light, and after that you get appropriate therapy, either endoscopy and banding, or beta blockers, or tips. So people should, all hepatologists are comfortable with all of that. So yes is the answer. But please do declare it to health insurance, okay?
Right.
It's really important.
Okay, last question. I was diagnosed in my 20s, but did not start ARSO until I was in my 40s, and I am an unresponder. My question is, does a delay in diagnosis or a delay in starting ARSO make it more likely that you don't respond?
Yes, there is data to show that very clearly, that the ARSO response, the longer you delay the starting it, the less likely you are to respond to it. So our friend Marco Carboni, has Marco done these sessions?
Yeah, absolutely, of course, yeah.
Right, okay. So that's Marco Carboni's work from Milan, great friend of ours, great friend of the PBC patient community. That's his work. He's shown very clearly that the longer you delay, the less likely you are to respond to therapy. And if I were you, I'd be going and asking detailed questions as to why you weren't treated. If it's 20 years ago, then it was much more, there was less clear-cut evidence about ARSO. You kind of, hindsight is easy. So, it was less clear-cut that ARSO is beneficial, but not really for at least 10 years. So it's been a clear part of the treatment guidelines for a decade. And I would ask questions as to why you weren't given it. There may be good reasons. I think that said, looking backwards, you are where you are. And so absolutely, you need to go on to second line therapy. Absolutely. And I wouldn't hang around too long with that. And in those sorts of situations, I wouldn't mess around with bezafibrate. I would go straight to OCA. You've just heard from the last person, their liver function tests have normalized. It is the more potent drug. So I think you want to be, most important thing right now is to get onto an effective therapy that controls the disease. And then you might want to ask a question as to why you weren't given, why ARSO wasn't used.
Perfect, thank you. And again, if you've asked that question, I know we met and we spoke at the conference. Give us a call and let's help you take that.
Now, 20 years ago, second line therapy didn't exist, that whole concept. So, in a sense, but 20 years ago, heavens above, it was 2003. So that stage, I think it was pretty widely accepted that ARSO is effective and the majority of people would be on it. When we started UK PBC in about 2012, 80% of people only in the UK run ARSO. It's now 95%, the audit tells us. So there was a catching up element. But yes, the disease becomes progressive. And I think, but the most important thing is get onto second line therapy. Asking questions about what did or didn't happen in the past is important, but not as important as getting on the right treatment. And the last thing you want is a defensive doctor who, argues you didn't need treatment, but to justify what they didn't do. If you're in ARSO non-responder bloods, you need second line therapy now. In this situation, OCA, and then see where we go, and then OCA, and then combination therapy if need be, and then you take it from there. But I think it's worth a question.
Okay, brilliant. Thank you. That's us. We overran. I apologize for that, but thank you very much for your time as ever.